Hello everyone, welcome back to my channel. So in this video we will be discussing about anti-cancerous drug, and the another group we will be discussing now is anti-metabolite. So what are anti-metabolite? So these are the analog which are related to the normal substrate, okay, of the DNA or coenzyme which are involved in the nucleic acid synthesis. And anti-metabolite, what does they do? They competitively inhibit the synthesis of this utilization of this normal substrate, or they themselves incorporated, and they will form dysfunctional macromolecule or non-functional nucleic acid, okay. So analog which are related to the normal compound of DNA or the coenzyme which are involved in nucleic acid synthesis, and these are antimetabolite which competitively inhibit the utilization of normal substrate or get themselves incorporated. They form the dysfunctioning macromolecule. So the first group which we'll be discussing in antimetabolite is folate antagonist. So the first drug that is present in this is methotrexate. So we have studied about this in previous videos about gout. Okay, now it is the oldest and highly efficacious anti-neoplastic drug. Okay, and what does it do? It inhibits the dihydrofolate reductase, we all know. And what is the function of dihydrofolate reductase? Dihydrofolate reductase help in the conversion of dihydrofolic acid into tetrahydrofolic acid, okay. So when if it is inhibiting the dihydrofolate reductase, so the conversion of dihydrofolic acid into tetrahydrofolic acid cannot take place, okay. And this tetrahydrofolic acid is a cofactor for the conversion of DUMP. What is DUMP? It is deoxyuridine phosphate monophosphate into TMP, thymidine monophosphate. So the DNA synthesis cannot occur because it is not occurring. This conversion is not occurring because we need THFA for it, and THFA is not produced because dihydrofolic acid is not converted into that, okay. So utilization of folate carrier, with the utilization of folate carrier, it enter into cell and it is transformed into a more active polyglutamate form by the enzyme that is polyglutamate synthesis, F polyglutamate synthesis, okay. You can remember that. So tetrahydrofolic acid, it is an essential coenzyme that is required for one carbon reactions in de novo purine synthesis. We have discussed an amino acid interconversion. So the inhibition by methotrexate, it is irreversible, and methotrexate kills the cell in S phase. So this is a S phase blocker. So antimetabolite like antifolate, pyrimidine analog, purine analog, all these are S phase blockers. So this question can be asked. It exerts major toxicity on bone marrow. The low doses given rapidly cause megaloblastic anemia, but high doses produce pancytopenia. So aspirin and sulfonamide, these are the antibacterial, enhances the toxicity of methotrexate by decreasing the renal tubular secretion. Okay, how that methotrexate is mainly excreted by tubular secretion. If these drugs are inhibiting these renal tubular secretion, so methotrexate will not be able to excrete out of our body, so it will be accumulate and it will produce toxicity. The toxicity of methotrexate cannot be overcome by folic acid, but it will not be converted to an active coenzyme, okay. So however, if we are giving folinic acid, that is N5 formyl THFA, rapidly reverses the effect. Thymidine also counteract methotrexate toxicity. So the toxicity like this anemia, so we can give folic acid, but after giving folic acid in methotrexate toxicity, this toxicity is not reversed. Why? Because folic acid has to be converted into an active metabolite, okay. For that it is a two-step process, and in the second step we need what? Dihydrofolate reductase enzyme, okay. And what is doing methotrexate is doing? Methotrexate is inhibiting this enzyme, so this enzyme is needed for folic acid activation. So this is inhibiting it, and it will not be converted into an active metabolite. That's why it does not help in this. But if we are giving folinic acid, which is already an active metabolite, so it is giving relief of this toxicity. So we use folinic acid rather than our folic acid in methotrexate toxicity. This is a very important question. So methotrexate is apparently curative. So what is the use is that is has been asked so many times. Choriocarcinoma, and the dose is 15 to 30 mg per day for 5 days orally. High dose of methotrexate, it can reduce remission in childhood acute lymphoblastic leukemia ALL. Methotrexate is widely used in non-Hodgkin lymphoma, okay, breast cancer, head and neck cancer, has a prominent immunosuppressant property that is useful in rheumatoid arthritis, psoriasis, and many other autoimmune diseases. Okay, now the another drug that is very important is Pemetrexed. So it is a new congener of methotrexate. Primarily it target the thymidylate synthetase. Okay, though it also a THF reductase inhibitor, and but the pool of THFA, the THFA is not that much reduced, that much it is reduced in methotrexate. So this Pemetrexed is having adverse effect like mucositis, diarrhea, myelosuppression are similar. These are very much similar to methotrexate, but there is another thing, that is head-foot syndrome. There is a painful itching, erythematous rashes, mostly involving the hand and feet. So they're very red. Okay, this syndrome is known as hand-foot syndrome, and it is very painful condition. So the low dose folic acid or vitamin B12 pre-treatment is recommended to limit the Pemetrexed-induced myelosuppression. Okay, NSAIDs should be avoided as they decrease the Pemetrexed clearance. Okay, so they can cause the toxicity of it. In combination with cisplatin, Pemetrexed is approved for the treatment of mesoepithelioma and non-cell lung carcinoma. Okay, and in combination it has been used for breast, bladder, and the colorectal cancer. Okay, so that's all for this video. Thank you for watching. Please subscribe and hit the bell icon.